Okay, so we would like to discuss doctor-patient relationship, a topic which is at the very heart of healthcare law and ethics. So, what is the doctor-patient relationship? What is the nature? So, to start with, we need to remember that the doctor-patient relationship is fundamental to practice of medicine because it serves as a very heart of healthcare delivery. Without the doctor-patient relationship, which I prefer to call the healthcare professional-patient relationship, we cannot be having most of the things that we'll discuss in this particular area of the law. Why did I say that I prefer to call the healthcare professional-patient relationship instead of just the doctor-patient relationship? The reason is simple. If you look at the activity of healthcare delivery or provision of healthcare, it's not just the doctor, it's not just the physician. It's a whole set of arrangements involving different professionals. And that is why I would like us to broaden it to look at the healthcare professional and then the patient relationship. Now, the other point to note is that the relationship between the doctor or the healthcare professional and the patient is very unique from other professional relationships in the sense that, uh, for other type of relationship, maybe you have like an engineer who does not do your work well, you can fire him. You have a lawyer who does not do your case well, you can fire him. And oftentimes, when people are going on appeal, they do change their lawyers. Of course, it's sometimes a bit funny, for the point of view of lay people, thinking that maybe the lawyer did not present the case well. That is why the party lost. It may be true, it may not be true, but the point we have noted is that it is a common observable feature to see litigants going for new lawyers to pursue their appeals for them. That tells us that, well, from their point of view, something has gone wrong. That is fine. Now let's come to the doctor or the healthcare professional. If something should go wrong, maybe an avoidable mistake was made in a procedure, surgery, or whatever, that is quite serious. And for that matter, there'll be so much consequences. No wonder Professor Margot Brazer and Professor Imake, in their work, they made observation, which I quote, that clients usually remain unemotional about their solicitor. If he does a good job, they may appreciate him. If he's incompetent, they sack him. He rarely beloved or hated. The family doctor arouses more intense feelings to meet their patient's expectation. And the family doctor arouses more intense feelings. When doctors meet their patient's expectation, they are rewarded by admiration and affection. Woe betide them if they do not. One error, one moment of exasperation or insensitivity may transform a beloved doctor into a hate figure. So this observation by these learned authors, in my humble view, is an apt description of what the reality is. You and I might have had experience of a healthcare, maybe other relative, being rushed to the hospital or something. If the healthcare professionals are able to help, you see them as the most important people on the planet. On the other hand, if they made a mistake and something should happen, you can imagine how angry you'll be and you turn them into a hate figure. So that tells us that the doctor, and for that matter, the healthcare professional, stands in a very unique position in relation to the patient. So therefore, how do we define this relationship? How is the relationship really like? Well, at the very core of the doctor-patient relationship, as we have noticed from the presentation Professor Ian Kennedy made in his famous BBC Roof lectures on Maxim medicine, which I've made you read, you will notice that there is a level of vulnerability and dependence that is uncommon in other professional contexts. The patient is very vulnerable. The patient is very much dependent on this professional. And patients, as we know, will place their lives and health in the hands of their doctors, entrusting them not only to make right medical decisions, but also to act with integrity, compassion, and respect for patient autonomy. On that basis, we could say that the relationship is underscored by certain essential qualities. And what are they? One is trust. Trust, the patients rely on the expertise of the doctor and their judgment, thinking that the doctor is the technical person and the doctor will always make a good judgment about what is in the best interest of the patients. So the trust is very fragile in the sense that if it is not properly handled by the healthcare professional, and there's a perception that the healthcare professional is being insensitive or trying to breach the ethical standards, things could really go bad. Let's suppose that you have like a male doctor who is attending to maybe a female, and the male doctor, for example, begins to be sexually interested in the female patient. Now, the patient at that point may not be thinking probably in terms of romance, but may become worried that, what about if I say no to this doctor? Is he going to take good care of me? Can I trust the things that he's doing? So these are some of the things. Another quality is confidentiality. The patient will share very private and deeply sensitive personal information with the doctor or healthcare professional, and it's expected that it will not be disclosed without the patient consent. Well, here we are not only talking about what the law imposes as an obligation, we are also talking about an ethical duty, acceptable, right conduct within the particular profession, that is medicine. There's also, of course, as we say, like the ethical care. There are a lot of ethical responsibilities in this relationship, including the fact that the patient should act in the best interest, what we call the paternalism, must provide accurate information to enable the patient make informed decision. The doctor must respect the patient's right to autonomy. And this is very important aspect of the relationship. We are mapping these things out so that as we look at certain aspects of healthcare law, it will become more sensible, or you appreciate it better. So therefore, we can say that the doctor-patient relationship or the healthcare professional relationship viewed through the lenses of the qualities which we have looked at actually go beyond just being a mere transactional service to become a unique social and ethical partnership. It's not like a one-off transaction oftentimes, and for that matter, it may be an ongoing relationship. And for that matter, doctors have the obligation imposed by their professional standards and codes, and also the law, to give priority to the health and dignity of each patient. So that is very important. And the quality of the relationship between the healthcare professional or the doctor and the patient is very much integral or central to patient outcomes and patient satisfaction. What the patient expects to achieve from a healthcare or clinical experience is very much dependent upon the quality of this particular relationship. For that matter, where we have like a positive relationship, is going to enhance the recovery. Don't forget, we have what they call placebo effect, right? Placebo effect, for example, somebody goes to the hospital and says that, oh, if my doctor gives me a prescription, I'll become better. So you go, the doctor is convinced that you don't really need anything, but because the doctor is aware of your own, psychological disposition, the doctor can, for example, prescribe something which is not medicine. Maybe be just water, just a liquid. But because you have that mindset that if your doctor should prescribe for you, you are going to be well. You take it and then you get better because of the trust that you've placed in the doctor. In the same vein, where you have like very poor quality of the relationship, it will also affect patient outcomes and patient satisfaction. So let us keep that in mind. We will not belabor that point. Now, if you look at UK, for example, we have what we call the General Medical Council. And in Ghana, we have the Medical and Dental Council. I mentioned the UK GMC for purposes of just a contest. They produce a document called Good Medical Practice. For many years now, almost every year, they update it. And what this document is supposed to do is supposed to be an ethical, guide, as it were. It's amazing. Yeah, so I was making the point that the General Medical Council of UK, they have, adopted a practice of compiling what their research, reveal as being an ethical or acceptable conduct for practice of medicine, reflected either from case law or from their own ethical debates. So they call it the good medical practice. And most of the things there are also reflected in some of the things that we talk about in our own country and provide a useful, context. So if you can just Google the Good Medical Practice, they have it like every year. Just run your eyes through it, and it will give you an idea of what they have identified as acceptable and not acceptable. So if you look at the 2024 version, for example, key behaviors required of doctors by the guide include one, politeness and consideration. Now, doctors are expected to treat patients with courtesy and respect, and that will foster an environment of openness and understanding. Of course, we don't have to belabor this point. Just imagine a doctor who is very disrespectful and arrogant towards the patient. It will let the patient be unable to even come out and share what the real problem is so as to be helped. Then honesty. The GMC guidelines talk about the fact that honesty is fundamental in the doctor-patient relationship. Doctors must provide accurate information about their patient to their patient in terms of their diagnosis. If they find something, they shouldn't hide it from the patient. But of course, there is also what we call therapeutic privilege. Therapeutic privilege simply means that a doctor who knows the psychological disposition of his or her patient, knowing that this my patient cannot handle, for example, this type of information, is also permitted by law and ethics to find a better way of getting it to whoever is supposed to be close to the patient, or even not to disclose it to the patient in a way which will worsen the psychological and mental health of the patient. It also talks about dignity, that patient dignity should be preserved, and it's part of ethical medical practice. Every patient has an inherent worth because the patient is an individual, regardless of the health condition of the patient, the background, or the beliefs. It doesn't matter the patient is a Jehovah's Witness or is a Muslim or is this or that. You have to respect each patient as individual. You have to show sensitivity to the patient's needs and values, and also ensure that whatever interactions you are going to have with the patient reflects a deep respect for their personhood. The guidelines also talk about privacy and confidentiality. Of course, privacy and confidentiality are essential values for the existence and sustenance of the healthcare professional-patient relationship. Just imagine if you could not be assured that what you are going to tell your doctor will just remain there, and then tomorrow is going to be a headline or it's going to be a talk of the town. People will not feel encouraged to actually open up to your healthcare professional so as to get right diagnosis and treatment. Then patient support and empowerment are also mentioned in the guideline, that there should be collaboration between doctors and patients. Now, healthcare is seen as a partnership. Partnership in the sense that it's not just the responsibility of only the healthcare professional. You, the patient, you've also got the role to play. So you've got to collaborate, you've got to cooperate. Now, if you look at the literature, there have been a lot of scandals. I mean, just one or two be mentioned. For example, you might have heard of one, Harold Shipman, Dr. Shipman. Dr. Shipman was a GP in the UK. He was convicted of meddling multiple patients over the course of his career. A doctor who is supposed to be taking care of your patient, if you check the record, I think he killed over 100 or so of his patients, gradually and incrementally. And certainly, that is a classic example. That is a classic example of how the doctor should not treat. Zach, you can go. I'm teaching online. Okay, thank you. It's a classic example of how a doctor should not relate to the patient. Patients come to have relief of pain or to have their life, if you like, extended or not to die immediately, as it were. But where you are just killing your patient, then what is the point? Another scandal is Dr. Clifford, Ayling. He too was found guilty of sexually abusing multiple female patients. I talk about that fact. Patients are vulnerable. It doesn't matter how beautiful or how attractive the patient you are dealing with is. You have to respect the boundaries and know that you are a doctor at that time. You are not a sexual partner, or you are not the boyfriend or the husband or the wife or whatever. So Dr. Clifford's Ayling's example is another clear case of abuse of power. And that has the unfortunate effect of causing widespread distrust in the medical community, especially people begin to doubt whether the medical profession can actually guarantee safety of vulnerable patients in clinical settings. Now, what are the implications of some of these scandals? Of course, there will be a number of scandals, a number of them, but we just mentioned this. So these scandals actually brought to the fore the need for regulatory bodies. Let's say in Ghana, we have our, what they call the Medical and Dental Council, uh, midwives and nurses council, pharmacy council, psychology councils, and other allied health professionals councils. They are supposed to exercise strict oversight over the various healthcare professionals in order to detect and address potential misconduct. You remember not too long ago, one doctor, is it Obefo or something, doing this body enhancement or botox enhancement cosmetic surgery, leading to the death of some people. These are some of the troubles that we have had. Again, there should be clear ethical guidelines and boundaries. And this should be done through continuous professional development. So the medical situation of Ghana, for example, they have the CPD they do in collaboration with the Medical and Dental Council. And you are supposed to accumulate certain credits before you can actually have your license renewed. There's also the need for public awareness and empowerment. Patients should be educated about their rights within the healthcare system. Thank God, per Section 167 of the Public Health Act of 2012, the patient charter has been incorporated into our law. And the patient charter, which is in the 6th or the 7th schedule of the Public Health Act, is a compendium of rights and duties of patients and healthcare professionals in the enterprise of providing healthcare, as it were. Just a minute. Yeah, so there's a need for patient awareness. patients will be made aware of their rights, especially in a part of the world where there's a thinking that when patients are being attended to by healthcare professionals as if they are doing them a favor, and because of that, they're going to treat them anywhere. So these are some of the things we should have at the back of our mind. Now we'll move on to look at the goals of medicine. So question is, what objective is medicine supposed to serve? In other words, what is the point about healthcare or medical practice? And that is important because that has an impact on the relationship between the healthcare professional and the patient. So we will look at them quickly and then move on. So traditionally, the goals of medicine were centered around saving and prolonging life, promoting health, alleviating suffering. And of course, they coincide very much with what the World Health Organization, WHO, has actually provided as a definition of health. And according to the Constitution of the World Health Organization, health is defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, unquote. So it's not just you not having disease or infirmity, which will mean that you are healthy. We are talking about your mental and social well-being as well. And for that matter, as we said, medicine seeks to save and prolong life. And that is why uh, when it comes to illness like emergency medicine and surgery, why do you have emergency medicine? In order to save life, to prolong life. Why do you do surgery? Something is going wrong in the person, we take it out so that it doesn't end the life of the person, as it were. And what that means is that uh, there is the need for timely and effective intervention. So when it comes to the doctor-patient relationship, time is of the essence, where doctors need to act, promptly and decisively using their knowledge and skills to prevent premature death. That should be done. But sometimes for certain health conditions, you doing something within 10, 15 minutes will determine whether somebody will remain alive or somebody's condition will be worsening or not. Another goal of medicine is promoting health. As we have seen from the definition of health by World Health Organization, it's not just the absence of disease or infirmity, but it's about mental and social well-being in a complete sense of it. If that is the case, then it is necessary for health to be promoted so that people will be aware of what is needed to be done and what should not be done in order not for them to even develop infirmity or disease, as it were. And this is also consistent with, as we have said, the definition or conceptualization of health provided by the the World Health Organization. So let us keep that in mind. And that is why a healthcare professional should not just be interested in waiting for patients to get sick and come for diagnosis and treatment. But more importantly, they should also be interested in, sorry, let me just collect something. Yeah, so a doctor should also be interested in encouraging the patient to actually live lives or engage in practices which would enable the patient, as far as possible, to avoid the incidence of becoming sick or having some infirmity. So health promotion is very important. Another goal of medicine is to alleviate suffering. We don't need to belabor at this point. Traditionally, that has been it. If something is paining you or something is not well in your body, what do? You go to hospital. Why do you go to hospital? Because you think that your suffering will be alleviated or the pain will be minimized, as it were. So, because of time, we will leave uh, some of these things because the points are actually repeated. You look at the notes. We look at the Ghana Medical Association. So, if you go to their website, they have their objective stated. They want to find out to what extent what the Ghana Medical Association have set it up have to do reflects the goals of medicine. So uh, the mission of the Ghana Medical Association, as I gathered from their website, was to advocate for health as a fundamental right and ensure that healthcare is equitable, accessible, safe, and appropriate for all Ghanaians. So that is their goal. And in that respect, we can see some points of intersection regarding what the goals of medicine are supposed to be, either traditionally or even in a contemporary sense, and also as reflected in the definition of health by the World Health Organization, that health extends beyond the mere sense of disease to encompass complete physical, mental, and social well-being. So what does it mean to say that health is a right? Well, uh, to say that health is a right would simply mean that just as at the global level is understood that uh, health care resources should fairly and equitably be distributed, made accessible and affordable. So there should be equitable and accessible healthcare, regardless of your geographical location, your circumstances. You should receive healthcare in the various ways that health has been understood. Another point from their vision, that's a Ghana Medical Association, is the emphasis on safety and quality of care. After all, what is the point if healthcare professionals are not going to prioritize safety and quality? People come to seek healthcare in order to minimize their suffering or pain, in order to prolong their lives. So therefore, where safety is not taken serious, then what is the point? Of course, there's also the need for collaboration with other professions and disciplines. Now we will look at the models, that is, looking at the doctor-patient relationship. What can we liken it to? How do we conceptualize it? So a lot of approaches or models have been provided. So we have the fiduciary model. There's a school of thought which says that the doctor-patient relationship is one of a fiduciary relationship in which the doctor is seen as a trusted custodian of the patient's health and well-being. And for that matter, the patient places his trust and confidence in the doctor, just like any fiduciary relationship, and expect that the doctor will act in the patient's best interests. And this view of the doctor-patient relationship is grounded in the ethical principle of beneficence, where doctors are morally obligated to prioritize the patient's welfare above any other consideration. So the key characteristics of seeing the doctor-patient relations traditional model is that we have a trust and loyalty, as we have explained. So trust and loyalty between the doctor and the patient. Then the best interest decision making. So here we have what we call the more or less like the, if you like, the paternalism, that the doctor is supposed to make decision based on what is most beneficial for the patient rather than strictly following the patient autonomy. Patient autonomy means what the patient will choose should be done, but where you view the doctor-patient relationship as one of fiduciarily, it's not so much about what the patient will choose, but what the doctor in his judgment considered to be beneficial to the patient. Of course, there are some limitations of this. When it comes to emergency medicine, it is good and I think perfect to look at the doctor-patient relationship as one of fiduciary. And the same thing also applies to pediatric care. Now, when it comes to providing medical care for children, because they are very young, they cannot even say what is really wrong with them. So seeing the doctor as a fiduciary is perfect in that respect. But then that obviously leads to paternalism, meaning that the doctor knows best, and the doctor assumes the responsibility for making decisions for the patient. Now, where the patient is not a minor, it's not like a child, or it's not an emergency situation, and then it's like a normal adult capable of making choices, then you may actually be curtailing the right to self-determination or the autonomy of such a patient. And that is the downside of this fiduciary model. Another way of looking at the doctor-patient relationship is to see it as a priestly model, or what we call the paternalistic model. So the priestly or the paternalistic model reflects the traditional approach to doctor-patient relationship, where the doctor assumes the paternal role, if you like, it's like the father role in guiding the patient healthcare decision. And it is rooted in the Asian Hippocratic ideal. That is, the oath of Hippocrates. Hippocrates was a Greek philosopher and a physician who trained people to also become physician under apprenticeship system. And before you started understudying him, you take the oath. And then when you are leaving, you take the oath. And that became known as the oath of Hippocrates, or what you call the Hippocratic oath, which in this day and age have been refined and it's become like a tradition in many medical schools, especially in the Western tradition, to have students to take the Hippocratic oath before they become doctors, as it were. So one of the things in the Hippocratic oath is what we call the principle of beneficence. That is, do good and do no harm, avoid harm. And this model, that is seeing the doctor as, from the perspective of like the priestly model, will emphasize beneficence and subordinate the patient's autonomy to the doctor's judgment. So in that respect, the doctor is saying, chiefly as a caregiver, make decision on behalf of the patient, assume that they know what is best for the patient's healthcare and welfare than the patient himself. So there's a minimization of the patient's autonomy. The patient is not really given the freedom to choose, as it were. The obvious limitation of this model is that it's seen as being overly paternalistic, treating the patient as if the patient is not capable of making choices regarding what he or she considers best for his life. Now, if we look at modern day patients, they expect to have more agency, more responsibility in their healthcare decisions rather than just leaving everything to the doctor of healthcare. Even now that we have the aid of internet, AI, and so on, people go online to actually read about their condition before they go to meet the doctor or where prescriptions are made. People will go online and read about them before they start even taking them. It tells you how enlightened patients have become, and for that matter, would like to have more say in decision regarding their healthcare and treatment. Of course, the Priestley model is seen as being outdated for lack of respect for patient autonomy, as I have explained. But when you are dealing with, patients in particular or specific contexts, for example, those who are highly vulnerable patients who are unable to make informed decisions, then in that case, it is a useful model. Then we also have the engineering model. That is, a doctor-patient relationship is likened to the engineering system. And how does that work out? So the doctor is seen as functioning as a technical expert or engineer, okay, who present facts and treatment options to the patient, but maintains an emotionally neutral and detached role. Just like you are, let's take the car, right? If you are like an auto mechanic engineer, for example, mechanic engineer is dealing with machines, as in the metals and so on. They don't have flesh. It's dealing with the bolts, spanners, and so on. So in the same vein, the doctor is supposed to just present facts and treatment options without showing any preference or any emotional attachment. And then, so such a model treats the patient in a very impersonal way and focuses on the mechanical aspects of diagnosis and treatment and leave the decision making entirely in the hands of the patient. So the doctor will say, okay, you ran the labs, you've done this, you've done this, these are what they are saying. These are the options, the A, B, C, D. Then the doctor will not say anything. So which one are we doing, sir or madam? Then the patient will have to pick one. And the doctor is supposed to have like a very detached, if you like, involvement. So that is the engineering model. So in terms of characteristics, such a way of conceptualizing healthcare professional patient relationship, we see objectivity and detachment. So the doctor provides information objectively and refrain from imposing his or her own value or preferences on the patient. We also have patient-driven decision. That is to say that the patient has complete control over the healthcare choices. The options are presented to the patient, and then the patient will have to choose which one should be adopted. What are the downsides or the limitations of looking at the healthcare professional patient relationship from the point of view of engineering model? Well, it's undermine therapeutic relationship. Human beings, we are flesh and blood. We have emotions, we have feelings. Empathy and sympathy, they are all part of us. But where you see the doctor as purely, if you like, an engineer, sort of, that aspect of the relationship will be lacking. Sometimes even how you show empathy and support can determine very much the patient getting better. Then another model is to see what they call the customer salesperson model. So here, it conceptualizes the patient as a customer with autonomy and control over healthcare choices. So just as you go to a supermarket, you take your, if you like, your basket, you pick, I want to buy sausage, I want to buy Milo, I want to buy milk, I want to buy yam, I want to buy that. And you pick which ones you want. In the same vein, the patient is seen as a customer with autonomy and control over healthcare choices. And then the doctor assumes the role of a service provider, and he is supposed to fulfill the patient request. Just as you ask the shop attendant, please, do you have sugar? You say yes. Do you have this type of milk, ideal milk? I don't want carnation, I want that. So the doctor is always seen as if like a service provider and supposed to fulfill the patient's requests. So in that respect, the doctor presents options and information without assuming responsibility for the patient's final decision. It's up to the patient to make the final decision. So the patient is seen as a consumer, and then the relationship becomes more transactional, isn't it? The interaction is seen as like a business transaction where the doctor provides services according to the patient preferences. Certainly, there is a problem with this model because it reduces the doctor's moral responsibility. It makes the doctor, if you like, become more and more morally unconcerned about the choices that the patient is making. It's just like an adult and a child being somewhere, and then a child taking a substance which is poisonous, but the child probably does not know very well that that is poisonous. And you, the patient, you, the adult, begin to behave well. I don't care. I don't care. It's up to the child. It's a similar to what is happening here, and that is not good enough. So let's keep that in mind. And finally, we also have what we have not in the last but one, we have what we call the collegial or the partnership model, where the doctor-patient relationship is seen as one of a partnership. So the doctor and the patient, they're all partners in one common enterprise. The enterprise of having the common goal of restoring and maintaining the patient's health. So it's collaboration. Each partner has got a role to play. There's supposed to be mutual respect, trust, and shared decision making. So the key characteristics: collaboration, mutual respect, shared responsibility. Now, this model can be challenging to implement when there are significant knowledge or power imbalance between the doctor and the patient. Especially so, the doctor is a very technical person, and the patient may not know much. So we have a serious asymmetry of information. So where we don't have the same level of information and knowledge, how can we collaborate meaningfully? So that is a challenge. And again, where the patient lacks capacity, like maybe the mentis, compus mentis, to be able to make like informed decision, or is a minor, as it were, then this model may not be the best. Then we also have the contractual model. So the contractual model, is based on the idea of symbolic contract or agreement between the doctor and the patient. So in this model, both parties have defined obligation or responsibilities, with the doctor providing medical expertise and the patient adhering to agreed upon treatment plans. So like it's a contract, you all have, just like a normal contract, you have your terms of contract, various duties or obligations. So the doctor has got his obligations to provide medical expertise, and the patient has also got obligation to uphold any agreed treatment plan. So that if you are supposed to take your medication according to certain regime, you're supposed to do that. If you're supposed to come for a review at certain intervals, you're supposed to do that. So this model emphasizes respect for autonomy. At the same time, it acknowledges the mutual nature of the relationship that is not one-sided. Both sides have got a role to play. There's a mutual obligations, respect for autonomy. Again, we have a limitation, particularly where we have a resource limitation. Power imbalance can arise because the doctor may have control over available treatment and resources, and that will limit the patient's options. Let's take when it comes to kidney disease, renal disease, and so on, and people will have to be on dialysis, for example, assuming there's only one, and we have about 1,000 patients that may need it. So if you're using this particular model, it doesn't really work well because the resource is very limited, as it were. So let us keep that in mind. So we like to look at the core principles of the doctor-patient relationship. There are certain bioethical principles which have been observed as being the right thing to do in the healthcare professional-patient relationship. So what are these core principles of bioethics? They are non-maleficence, beneficence, autonomy, and justice. We talked about them in our previous lecture, so I'm just going to run through them quickly so that we can cover these grounds since we are behind time. Now, these core principles of bioethics shape the doctor-patient relationship and help doctors to make compassionate, respectful, and fair decisions that uphold the dignity and rights of patients. So, in the rare practice of medicine or healthcare, when you try to strike a balance between these principles, you are able to make right healthcare decisions, ethical healthcare decisions, which will involve complex situations where there are conflicting ethical concerns. And that is why it's important. Ethical dilemmas are part of medicine, are part of healthcare. Ethical dilemmas in the sense that you find situations in which you have more than one way, and each of them have got certain difficulties. Which way should you go, as it were? So we have non-maleficence. We've talked about it already, which simply means that do no harm. That is to say that the healthcare professional is supposed to avoid harm. They must consider the potential for harm in all medical decisions and avoid treatment which will lead to unnecessary suffering, pain, or injury. So the harm here includes physical harm, psychological distress, and breach of trust. Related to the non-maleficence is also the need to do risk-benefit analysis. That if you are going to do, for example, surgery or other invasive procedures, if it is possible that harm cannot be avoided, if it's said that harm cannot be avoided completely, then you need to actually do a careful analysis. How do you balance the need to avoid harm with the need to do good? What are the anticipated benefits of the treatment? The expected benefits of the treatment? Will it justify the inherent risk? There are some drugs, for example, some medicines. Sometimes if you take the trouble to read the label, you may even say that, why did the doctor prescribe this for me? I'm not going to read it. I'm not going to take it. But sometimes Despite the risks, the contraindications, and so on, what is going to help you to achieve may far outweigh the adverse side effects associated with it, as it were. So risk-benefit analysis is very important, and that is what is impelled by the ethical principle of non-maleficence, that do no harm. Then, patient perspective also becomes important because non-maleficence will require the healthcare providers respect patients' values and preferences. A patient, for example, may view certain side effects as more harmful than the doctor perceives them. So their perspective should be integrated into care decisions. I'll give you an example. When it comes to, let's say, prostate treatment, and even when it comes to blood pressure, there are some treatments over there for some men because it will reduce their potency or their ability to have their sexual activity. They'll say no, they don't want it. But they may be effective treatment to let them actually get, but because they are going to lose the ability to exercise a certain biological function, they'll say no. So the doctor will have to respect that. So maybe there may be a treatment which may not uproot the problem or which may be short-lived. But if that's what the patient says, so be it. So non-maleficence is an universal obligation in medical practice, and avoiding harm is often seen as the minimum ethical requirement in healthcare. So when it comes to injection and all that, you don't do it anyhow. You have to be mindful of the need to avoid causing unnecessary pain and side effect to the patient. And we also have beneficence. Beneficence is the ethical principle which requires healthcare professionals not to act in the best interest of the patients. So we've talked about it also variously. So beneficence promotes the welfare of the patients and the need to take proactive steps to prevent harm to the patients. We notice that non-maleficence will emphasize avoiding harm. Don't cause harm. If you like, it's negative in its stipulation. Beneficence goes a step further. Beneficence is that do something for the good of the health of the patient, to alleviate suffering, to support overall well-being. So beneficence require acting for the patient's benefits. What is the best outcome for the patient? And this will involve considering the patient's medical needs, personal values, long-term health goals, and so on. So for example, if you are treating like a female and you are going to do a certain procedure, you need to find out, does she intend to have children again? If she intends to have children again, certain medications or procedures may affect such a desire. So you may need to use an alternative one. So that is very important. Beneficence also requires that you prevent harm. You are supposed to prevent harm wherever possible. And this will include taking proactive measures such as offering preventive care, providing accurate information. Then beneficence also means that you need to actually respect patient choices. Why it is necessary for you to do what is in the patient's best interest. It must also be balanced with respect for the patient's autonomy. The patient has also got the mind and his own life vision. So you must factor that into your calibration while you are seeking to do what is good for the patient. Another bioethical principle is autonomy. Autonomy is the ethical principle that acknowledges a patient's right to make their own decisions about their health. And this is central to respecting the individual's freedom, dignity, and personal values so that they're empowered to make informed choices about their treatment. So, critical to autonomy is informed decision making. Autonomy is meaningful only where the patients are well informed about their healthcare options. In other words, they're given enough information about the prognosis, the diagnosis, treatment options, and so on, so that he or she will be able to say, okay, this is what I want because I have considered all this and I think that this is what is good for me. It also includes respecting personal values. That is the patient, as I've explained already. Then it also requires supporting decision-making capacity. Autonomy means that before you can exercise your right to self-determination, you can make autonomous decisions. You must have the capacity to decide. You must have the mental capacity, for example. So they go hand in hand. Another bioethical concept is what we call justice. Justice. And the principle of justice here emphasizes fairness and equity in distribution of healthcare, especially when it comes to treatment and opportunities for care. Because we have a resource limitation, there'll be a need to ensure that there's equitable access to care. How do you decide who benefits from the limited care available? How do you do it? If you go to UK, for example, they have this body used to call the NICE, National Institute of Clinical Excellence. They came out with a formula called the CALIF, quality adjusted life expectancy. So that where they need to decide whether a certain expensive limited treatment available should be given to patient. How do we select the patient? They will do certain computation, use certain information about the patients, and then make a determination as to who is going to be selected. But the bottom line is that there should be fairness, there should be equity in determining who get access to limited care available. There should be fair distribution of resources as well. And of course, it also involves respecting social and ethical obligation. So let us keep that in mind. When you have the notes, I'll give you some practical scenarios which you can read. So we will draw the curtain here, and then I'll take questions so that tomorrow when we meet, we continue. So if you want to ask a question, please put up your hand.